Good afternoon, colleagues and professors, and thank gentlemen for your introduction. My name is Wen-Yi Yang, and my colleague's name is Dr. Zhang. So we are going to, first of all, I would like to congratulate to the first two presenters. I think they present very nice two real cases, but we are going to present the cases which is relatively common, and we're confronting almost every daily practice. So I will just first introduce to you, summarize the very the simple medical history. This is Mayor, 29 years old, admitted to our hospital due to infection of upper respiratory tract on the 2012 with extremely high office blood pressure of 230/150. And he also claimed fatigue, but not really severe dyspnea, no previous history of hypertension, no history of sleep apnea. And he reported his father had hypertension, and he don't smoke, don't drink too much, and don't have the drug addiction problem. And he didn't receive any treatment before go visit the emergency room. And we did, of course, the physical examination at the beginning. So first of all, we can have a look that actually this patient is obese, and with a BMI of 33.7 kilogram per square meter, and the bilateral jugular vein signs is negative. And we also checked the lung signs, and they had rough breath sounds, no dry or wet rares. And we also detected the enlargement of left ventricular heart with a heart rate of 100. The heart rhythm is regular, no murmur, and the hepatojugular reflection sign is also negative, no edema of low limbs. So what we would ask expert here to, what you are going to do for the next day? What kind of examination you would suggest for this patient?
Okay. Comment? Microphone, please.
I guess this patient is young. He's having a very high blood pressure. These two are indications to go and look for seriously about secondary cause for his high blood pressure. After that, I'll go for the number 2 screening. So we'll go for ultrasound if echo has been done, and as well to evaluate better the fundi. If all these are fine or lead me to any direction, fair and good. Otherwise, I'll go and go deep in the history and the family history as well to look for any leading track for further investigation before going further.
Another comment? Please, that microphone over there. Oh, sorry.
I think in this young and obese gentleman, I need to look for the history of obstructive sleep apnea, because it also can be part of the
They
causes.
reported no sleep apnea history, but
another thing is the this amphetamine usage. Even though he denied, but we still have to check for the urine. For the substance abuse.
very good. Microphone over there.
Hi, I think.
Please, over there, microphone. Very good idea, because okay, so it means please.
Was the patient very fat?
Yes, that's what we.
33.
The BMI is 30.
Did he have a history of? Sorry. The diabetes.
We will answer this question.
We will answer this
on
question.
the next slide.
Yeah.
I'm a vascular surgeon, so if the patient comes to see me, I would first check the renal artery.
Renal artery.
Yeah.
Renal artery. Okay. So we have some suggestions. So we need to first for diagnosis and clinical evaluations. Probably we will move further
Okay,
with
Dr.
more
Zhen-Yu, could you
information
tell us what you
and tell us what you did.
Yes.
So all are good, very good suggestions. I think this is what we did for the chemical examination. So we first checked the blood glucose. Indeed, this patient has a very high levels of random blood glucose, and also the fasting glucose is high, and HbA1c is also high. And then we check the potassium and sodium. So the levels are normal, within the normal range. But the serum creatinine, it's within the upper limit. So the serum, of course, you can see here. So the serum homocysteine is above normal. Also the urinary acid. Uric acid, sorry. And the HDLC is slightly above the threshold. We also tested the troponin I, but we tested for 2 times. And both of them are normal, within the normal range. However, this patient has a very high levels of BNP, and also the urinary albuminuria levels is above normal. For the additional examination, so you can see the ECG is sinus rate, and also the it's a little bit high. I mean, the heart rate is a little bit high. It's more than 100 beats per minute. And you have a depression of ST segment, but it's not specific. With echocardiography, we could see the enlargement of left atrium and also left ventricle internal diameter during the end diastole is enlarged. And also the left ventricle posterior wall and the septum wall are hypertrophic. But this patient has only ejection fraction of 33%. And we could see this is a global dysfunction. We cannot see the segment dysfunction in this patient. And also, of course, diastolic dysfunction, because it's very common in the heart failure patients. About 50% of them has diastolic dysfunction also. For the chest X-ray, the findings are confirmative with the echocardiography, so we can see the enlargement of left ventricle. And we also do, as what you suggested, we also monitor this pulse overnight oximetry. So it's normal. We didn't see any evidence for the sleep apnea. Then we monitor 24-hour ambulatory blood pressure. As you can see, so 24-hour blood pressure is high, and also daytime and nighttime blood pressure. So what would be the next step? What's your proposal?
Yeah, we have a lot of data now. Please, please over there. Yeah, here, yes.
I think this case is emergency hypertension in view of the blood pressure is more than 220 and 120, and with the evidence of organ damage where there is a reduced ejection fraction and the ST depression. So I think the main thing here, we have to control the blood pressure slowly within 12 hours. I mean, cut down the blood pressure reduction by 25% within 12 hours. By using the infusion of the beta
normal
blocker.
level.
Huh?
Within 12 hours to normal level?
No. The reduction of 25% of the systolic blood pressure within 12 hours, because this is emergency hypertension with organ damage, which is different from the urgency, where they can reduce 25% within 24 hours.
Okay. Any other suggestions? Comments? Yeah, please. Yeah, yes.
I think this is a case of metabolic syndrome, apart from the hypertensive crisis, and we can see all the increased blood sugar levels, and also creatinine, hyperhomocystinemia, and I think we should go with ultrasound, and then probably check for CT.
Ultrasound for what?
Ultrasound for brain, sorry, for the adrenals, and then we'll go for a CT.
Okay. Another comment? Okay, over there. Yeah. Please.
I propose to examine the aldosterone renin ratio and maybe cortisol also for excluding the endocrine hypertension because he is young, he has the low potassium ratio level, and he has a very high level of blood pressure.
Okay. Please.
I do emphasize the first message that ultrasonography to be imaging has to be done for the adrenals and renals, and the cushions with dexamethasone suppression test to be done as far he is already obese and he having this very high blood pressure. Whether to control or not the blood pressure is something else. I need not within the scope of this discussion, I guess.
Yeah. Okay. Any other suggestions? Otherwise, please move on. Tell us what you did and the priority for both diagnosis and treatment, please.
I think quite a lot of audience already said that we should study the treatment, but of course we studied, but we would like to put this part a little bit later on. So we talk about the diagnosis first. So, but actually I also would like to highlight here, actually, if you look at the report of 24 hours blood pressure monitoring here like that, you have 24 hours average blood pressure, you have daytime and nighttime, but you can observe obviously here, you have relatively low daytime, but relatively high nighttime. So do you have any
if I may, lack of nocturnal dips suggests secondary hypertension, especially in 29-year-old man.
Yes? Any comments from the audience? Do you agree? So please, please move on.
So I will provide the detailed individual monitoring readings here. So actually, you can see here from this patient, we have the daytime readings, and we also have the nighttime readings. I'm sorry, why the nighttime period is not showing here. So you can see that the daytime almost equals to nighttime. But one of the quite interesting thing here, actually, we observed is the nap period. So conventionally, actually, I'm not sure how, but in your clinics, we just generally use a short time fixed period to define the daytime and nighttime. But sometimes you need to be careful because I think the guidelines recommend all of us to, when you are going to do the IBPM, you should record the diary parallel. It's very important, especially for Asia people, I think.
Siesta dipping. Siesta dipping, that's very typical in China and South Europe, Spain and Italy. Please.
So, but anyway, if you exclude the nighttime, the nap time, and if you just take the real sleeping period to ask the information from the patient, and you still can see that actually this patient still have similar daytime, nighttime, is certainly a non-dipping patient. And as Professor said that actually you might suggest some the secondary hypertension.
Please. Microphone, please. Just a minute.
I think it is difficult to say that this is a non-dipping patient because you can see that during the afternoon nap there is a typical dip. So the alternative way to look at it is that something is going on during the night. And if you look at the curves, you can see, I think, quite vividly, there are some peaks during the night, suggesting to me that perhaps this patient was up during the night, perhaps to pass urine. Someone with severe hypertension might have pressure naturalizes during the night. So I'm not, because he was certainly dipping in the afternoon where the sleep is shorter, I'm not sure that he can be categorized as a non-dipper, and perhaps there's some sort of behavior because of which he gets up at night and therefore the blood pressure, the nocturnal blood pressure is elevated.
Yeah, he emphasized the importance of diary. we always need a diary for 24-hour blood pressure monitoring. And yes,
a
one more.
little comment. It is not only the late night; it is the whole night. Is more than the whole day time. So it may give that there is some behavioral issue or something else. We have to look for it.
Yeah.
We don't know.
Yeah. Just one more comment here.
Can I comment on the blood pressure variability on this patient? Because I can see the minimum and the maximum level is a very big range. So I feel that this blood pressure variability on this patient is very high. So it could be contribute to this.
To the risk.
Yeah. Yes.
Yeah,
Okay, please.
Actually, I would like to make one more. I'm sorry. Actually, this ambulatory blood pressure monitoring we're taking in the hospital. So I'm not sure whether you are going to do that for these patients, because generally for the clinical practice, we would like to like the patient to have their generally daily life. But I think stay in the hospital, they don't have any physical activity during the daytime. Maybe that's one of explanation for this so-called non-dipping or phenomenon, let's call it. So.
And I think the other reason is because this patient is taking this ambulatory blood pressure in the hospital, and during the nighttime, the nurse will check the check the unit from time to time. This is also, I mean, the patient cannot sleep very well in the hospital. That's very common.
So here actually is the suspicion of the diagnosis. Well, almost list all of these diagnoses here. But actually, of course, for the general things, it doesn't matter too much. I think it's very clear from all of these examinations. But how do you think about what is the hypertension diagnosis, primary or secondary? Is heart failure, and then what is the cause of the heart failure? Yeah.
Yeah, please, the microphone.
I think it must be assumed that it is secondary.
Wait a second. Yeah.
I think it must be assumed that it is secondary. At the age of 29, he has left ventricular hypertrophy. He has nephropathy. So he must have had this very high blood pressure for a long time. And at such an age, I think we must assume it is secondary until we don't find a cause. The presence of uncontrolled diabetes certainly contributes both to the renal, to the nephropathy, and probably to the cardiomyopathy, unless he has pheochromocytoma, which can also be a cause of hypertension at a young age and cardiomyopathy.
Okay, another comment.
I do agree he has underlying secondary cause of hypertension, but I think the pseudoepinephrine could be cause him to have a high, his blood pressure high because he has admitted for the upper respiratory tract infection. He could be on pseudoepinephrine, which cause the blood pressure to be higher.
Yeah.
I think first we need to be sure that this patient had hypertension. So because we already have seen that there is a very large blood pressure variability during the ambulatory blood pressure monitoring. So I think we need to repeat ABPM.
Yeah, any other comment?
Just little. At this time, no cortisols and no thyroid done.
Yeah.
Up to this level.
Yeah, very good point. So all the diagnoses for now are based on the data we had in the previous several slides. Please, probably we move on.
So about the question that Professor Lee just raised up, we repeated the measurement of 24-hour ambulatory blood pressure. And of course, the high blood pressure, the hypertension, is confirmed at this stage. And secondly, to exclude the secondary hypertension, this is all the examinations that we did. So we measured the ACTH, cortisone, aldosterone and also renal activity. And all the examinations are within the normal range. And we measured it according to the guidelines. And this patient was in the supine position. And also for the other reasons for hypertension, for instance, the thyroid dysfunction, we also check it and it's within the normal range. We did the adrenal gland CT and CTA. The result is normal. And then we do this pituitary body MRI, and the result is also normal. So what would be the next step? Do you think we exclude the secondary hypertension?
Any other suggestions? Microphone, please, over there.
Still, I'm emphasizing cortisol with suppression done or not. This is just the cortisol readings without suppression. Okay.
We have it day and night. It's measured at 8 o'clock a.m. and 4 p.m. So it's two.
And repeated after suppression with dexamethasone or not?
Suppression.
Suppression. We didn't.
we didn't.
Check it because the result of the cortisone is normal, so we didn't do the suppression test.
Okay.
It must be.
There is a comment at the back.
I would like to emphasize on the hyperhomocystinemia, which could be probably causing increased vascular stiffness and increase in the hypertension. So I think we can go with the secondary hypertension as it is a metabolic cause.
Okay, that's all very good, but we want to know more about the kidney.
Yeah.
Because we've excluded the endocrine causes, but I haven't seen enough of kidney detailed investigation.
Both the renal artery and the kidneys, please.
Yeah, certainly we did the renal artery CTA for this stage. So as you can see, as you can see here is the CTA reconstruction, the aorta and two sides of the renal artery. And if you look at this image, and what's your interpretation, and are you going to link the renal artery stenosis to these cases or some interesting part? Thank you.
Any comment from the audience? Yeah. Please, microphone. Wait.
From the outset, the low plasma renin activity does not necessitate renal artery imaging.
Yeah. Okay. Please.
So we have another question. What do you think the cause of heart failure?
Yeah, that's something I think you must have a lot of comments.
Several reasons. The first one is the patient is young and obesity, and I think maybe something social with insulin resistance. You know, insulin resistance is social with hypertension. This is the first one. And the second one, we have found some abnormal of candidate. So the blood sugar is narrow. We just found that. So I think this is the reason. And from my recent research, we also found some the results may be associated with the peripheral vascular resistance. Yeah.
Peripheral. Please.
So for the causes of heart failure, do you think we can exclude acute myocardial infarction? Yeah. No? Who said no? Give me some reason.
That's good to hear different voice.
Yeah.
I think this patient is too young to assume that diabetic cardiomyopathy had occurred to such an extent. And in diabetic patients, premature myocardial infarction is likely. The presence of renal atherosclerosis, although minimal, in such a young subject can support to some extent the possibility of coronary atherosclerosis, and I think that acute past myocardial infarction is the leading diagnosis of his heart failure. Again, unless he has pheochromocytoma, which could cause hypertension, cardiomyopathy, and diabetes.
But they reported normal normal catecholamines and also normal
Normal troponin.
Oh, normal.
Yeah.
Yes,
so
please.
we measured troponin for 2 times, and both
Troponin
times.
I
Yeah,
at the
troponin I.
beginning of the emergency. Yeah.
So both times they are negative, and also you didn't see the segmental dysfunction. It's a global dysfunction, and also for the electronic for the EKG, it's only the depression of ST. For such a young patient, normally we would expect it that he has elevated ST. Elevated ST myocardial infarction, not non-ST elevated myocardial infarction. Of course, you can see that he has diabetes, and maybe you have a very severe artery impairment. For instance, 3 big arteries all have impairment. Then, I mean, this is a possibility. But then the troponin I, we repeated for 2 times. So I think this way we can exclude. And this patient don't have any symptoms of chest pain. This is also another evidence that we can exclude acute myocardial infarction.
Yeah, please.
We also did actually.
Of course, just the reason that you mentioned, this patient is obese and has diabetic, and we think it is rational to measure the coronary CTA, but the result is normal, so it's confirmatory that this patient don't have any coronary heart disease. Do you think we can exclude myocarditis? Myocarditis.
Myocarditis. Any comment from the audience whether we can exclude? Zhang, please.
What about a very simple diagnosis? This is a patient with essential hypertension, and he got heart decompensation because of his high blood pressure. And this is how I would approach the patient. And then my next question is, how would you treat the patient? So what would you do?
Again, treatment?
Treatment. I think treatment is most important.
Okay, but we should first exclude myocarditis. Okay. Any other comments on this? Otherwise, I will move on, please.
Okay, so I think we can exclude this. Of course, this patient has a history of upper respiratory tract infection, but then you can see the troponin I. We repeat it for 2 times. If this is the case for the myocarditis, then the troponin I should elevate it. So this is the reason that we exclude this myocarditis. And just as Professor Sasson said, this is, we think hypertension is the reason for this heart failure. This is the cause of heart failure.
But you still have to look at the influence of lung infection that can exacerbate heart failure, even though heart failure was caused by hypertension, and this patient was hospitalized because of upper respiratory tract infection. This infection can also exacerbate heart failure in many cases. Please.
So I think yes, of course, I agree with Professor Wang for these cases. But we can also thinking about, let's treat the patient afterwards to see how about the heart failure recovery and the prognosis of the heart failure. I think maybe you can answer some part of the question. And first, our final diagnosis we made like we made thinking mainly the primary hypertension with very high level office blood pressure and extremely high risk group. And we were thinking about the heart failure were caused by the hypertensive cardiomyopathy and with severe left ventricular enlargement, with chronic heart failure, and with symptom New York Heart Failure Association classes 2, grade 2. So of course for diabetes, I think it's quite easy to confirm, and also for the macroalbuminuria. But do you think it's a chronic kidney disease, or it's like acute kidney disease?
Any comment on this question? If not, oh yes, somebody here.
Hello, sorry, I've got several questions. First, for this patient, if you think the heart failure is due to hypertension, probably that means the patient have got chronic hypertension. Is that the case? And I may have missed that. What about the fundus examination? Did you see any diabetic retinopathy or hypertensive changes? Because if you think this is CKD due to say emulation of diabetes, then most likely there should be some changes, say at the retina. And this is the first question. Second question is that you mentioned about 30% renal artery stenosis. Do you think this is a possible cause of the hypertension, or that's just an incidental finding? Also, with renal artery stenosis, do you try to examine for radial femoral delay, because there could be a possibility of, say, Takayasu's disease? So these are all my questions. Thank you.
Yeah, please.
First of all, I would like to start with the easy one. Actually, I think very few of us would agree that actually the renal stenosis with such a 30% will be the causes of hypertension. Actually, I don't think it will be some kind of a hemodynamic problem. But for the macroalbuminuria, actually, I think in this case, for this moment, it's very difficult for us to determine what will be the causes. But we will continue. We will tell you more.
Was the fundus examination entirely normal?
Sunday.
I would expect some changes.
Retinopathy, whether the patient had.
This one, we also check it, and it's not normal. I mean, this is just the sign of the duration of diabetes. So this patient already has some organ damage. So this is we can justify that the diabetes is already lasted for some years, but we don't know how long it has been lasted, because this patient don't have any symptom before the admission of this to hospital this time.
On the retinal changes, what was it? Any diabetic retinopathy?
Retinopathy.
Retinopathy. Do you see any changes due to the in relation to the diabetes? Because he has got suggestion of retinopathy. Then eye changes.
I think that's a very good suggestion. Unfortunately, we didn't do that. But actually, yeah, that's in the
Yeah, that's actually very important to look at the founder, because it is very important for diabetes. It is important for such severe hypertension. So that's I think something you should consider. Any other comment, please, at the back side, Dr. Zhang.
Have you ever measured the size of kidney, and have you ever did I think you must have did the regular blood test. The patient has anemia, which is most common in chronic kidney diseases.
We did the echo, but that's normal. In the echo is normal.
Blood routine test.
Exactly.
Whether the patient had anemia.
I just want to comment one. So the macroalbuminuria, if you want to diagnose the chronic kidney disease, one test is not enough. So you have to repeat it at least after 1 day. And then you have to see whether this is still lasting.
Microphone, please. Where's the microphone?
Because this patient has this acute respiratory Because this patient has acute respiratory tract infection. And also this is a reason for the macroalbuminuria. For some patients, we see this. And another reason might be the diabetes, as what you suggested, because the diabetic, it's already lasts for some years. So this is also one of the reasons. Another reason maybe because the high blood pressure is also, we have a lot of blood load in the kidney. So this also may cause the kidney injury. We think that's the reason. But whether it's chronic or not, we cannot conclude this at this moment. We need a repeat measurement.
Okay.
And I'll also come back to the question of the anemia. Actually, we did check it, of course. There is nothing in this case. I see the patient don't complain anything about that, and also the routine blood tests were normal, and so that maybe as what you suggested might be indicate it's not the case of the chronic kidney disease. But actually, we highlight this question. We raise this question actually is that we need to during the clinical practice don't avoid actually neglect that actually for the very high, extremely high blood pressure actually can cause the quite acute kidney injury, and with this macroalbuminuria.
Can I add something?
Yeah.
So it's very good that you honestly told us that you didn't look into the fundi, but for me that creates an additional diagnostic problem, because with a presentation of blood pressure 230 over 150, this could be malignant hypertension. And if it is a malignant hypertension, then this is a presentation that includes kidney disease, acute on chronic perhaps, on the top of diabetic nephropathy. So my problem is that I will never now know whether that was a presentation of malignant accelerated hypertension or not, because without fundi, I will never know. And I have a chest pain when I hear this.
So I think that's the reason why we didn't check it, because this patient didn't have any symptoms with eyesight. He can clearly see it, and he didn't have any headache. Of course, it is not the absolute evidence, but I think that's the reason why we didn't change it, we didn't check it. And another reason is because we lower the blood pressure immediately with the intravenous medicine, and the symptoms is released very fast.
Yeah, please. Yeah.
So for the treatment of this hypertension, sorry.
Yeah.
Yeah.
Yes. Please.
For the treatment of hypertension, what kind of drug would you use?
Yeah, any suggestions from the audience? Which drug would you choose?
I will use lapidaral infusion.
Okay. Please.
So, according to the guidelines for this young patient with an age of less than 55, and this is a non-black individual, we could start from ACEI or ARB or a beta blocker. And if the blood pressure is not very well controlled, we could consider to combine either calcium channel blocker or diuretics. If the blood pressure is still not very well controlled, we would use calcium channel blocker, diuretics, plus ACEI or beta blocker. And at the end stage, if we think this is a resistant hypertension, we should use aldosterone. We should use aldosterone antagonism. For instance, the spironolactone. Sorry.
Spironolactone.
Yeah, spironolactone. Yeah.
Yeah, please.
And for the selection of the medicine, I think the forgiveness is very important. We need to select the medicine with a long half-life. So this is to make the blood pressure lowering effect very stable. For instance, the amlodipine. Of course, you can see here. If you only take 50% of the dose that doctors prescribed, you still can have a very stable level of blood pressure. And the green line indicates minus 15 millimeter mercury. So this is why we choose this long half-life medicine. And in this case, Wen-Yi, would you mind?
Yeah, okay. So because we repeat it again and again, for such a high blood pressure, what we should do emergency, because we didn't mention that part, because certainly we will do it, because I think it doesn't matter. So we will just use the intravenous drug to temporarily control the blood, and also related to left ventricular load to release the symptom. And of course, we also initiate the anti-diabetes treatment, and also we combine several drugs, including the diuretics. And then after, I think, 2 weeks and more than 2 weeks, I think the patient was discharged with the office blood pressure 168 over 112 millimeter mercury.
But still in stage 3 hypertension. Okay, please tell us. Yeah. Yeah. No. No. Yeah, one more. No.
So the next question would be, is this a resistant hypertension patient? Is it or not?
All agree. Please.
All agree.
You see, nobody.
Okay.
Object.
So, of course, we do the 24-hour blood pressure, and we see is this patient has hypertension, but we forget that could be the reason. That could be another possibility that this patient had pseudo-resistant hypertension.
No, because you did already many times of 24-hour blood pressure monitoring. Okay. Any suggestion? Because we don't have much time. We're running out of time. If there is,
we now need to hear this
yeah.
story to the end because we're running
Yeah.
out of time.
Yeah.
Yeah. Just one more, because we didn't check the adherence of this patient. Of course, we checked the 24-hour blood pressure, but we didn't check the adherence of the patient. So how can you exclude the possibility of pseudo-resistant hypertension? Okay. So for this patient, we used the Morris-Guy questionnaire. Of course, this is not the best way to assess the adherence, because the golden standards that are proposed by the guideline is the measurement of the urine of blood of the metabolites of the drug. But of course, we didn't do it in this case. So for this patient, we think we checked this questionnaire, and this patient has a very good adherence. That's why we proceed to the renal denervation.
Yeah, so actually, the patient was admitted to our hospital in 2012. Actually, that time is a hot point for that, just because of the relief of simplicity too. And we were motivated to do the renal denervation. Actually, that was the first case we did in our hospital. And according to the CTA and also the renal artery angiography, actually you can see that the anatomy is very suitable for this renal denervation, because we can do it outside several sides. So that's what we did following the procedure what reported in Simplicity 2. And then we did the ablation by using the Simplicity, the first generation, one tip, the device. After the renal denervation, there is no complication, and the urine analysis is normal, and no any other complication. And the in-hospital monitoring blood pressure was, and then we follow up this patient for until now, it's almost 6 years. And in this first month, you already observed that actually the office blood pressure decreased, and we also already, because of the macroalbumin problem, we also already stopped the diuretics, and then we continue to follow up this patient and decrease the dosage of the antihypertensive treatment drugs. And actually, the office blood pressure is well controlled, as well as 24 hours blood pressure until now. And also ECG turned to be normal, and urine albumin actually now I think is normal, and left ventricular function recovered at 6 months to left ventricular ejection fraction 66, and remain to now the normal left ventricular function. And then Actually, our conclusion is that lifestyle changes maybe is also helping in this case to optimize medical treatment, remain the first-line therapy, and the most recent trials such as Spiral Med-Off and Med-On are reviving the renal denervation recently as a treatment modality of hypertension. But for the treatment-resistant hypertension should not be excluded from the new clinical trials because they are now focused on likely the treatment-naive or not very high treatment-resistant hypertensions. They're trying to exclude these people for the clinical trials. Thank you.
Okay, thank you very much for the excellent presentations and also, of course, for the discussions from the audience. You still have a question? No, we don't have time. Sorry. Last question. Very short question and very short answers.
Old patients with heart failure, how to make his EF value stable? Because I just see you use 3 to 4 cases for hypertensive treatment. Yes.
Yeah.
Yes, but no one is associated with the small vascular resistance. What I mean is the small vascular resistance, the small vascular construct and the blood sugar increased, right? But during this, I didn't see any drug to show this.
Yeah, they use
Other questions?
ACE inhibitors.
Yeah.
They use ACE inhibitor. Perindopril.
And
it's very strong in dilating the small arterioles. Yeah. Okay. Do you have any comment? Very short.
Just to thank the chairperson for giving us the opportunity to
Yeah.
present.
Okay.
And for the audience.
Okay. Thank you very much. And
Thank you. Thank you.